There we go. Oh my goodness. Thank you so much. I am so excited to welcome everyone to day 2 of the 4th annual Joining Our Voices virtual symposium. We are so excited to jump into our session today, Conversations That Count, Aligning Care with Goals for Every Patient. We have an amazing panel. We already were talking just a few minutes ago, how excited we are. If you missed yesterday's wonderful session on when wishes collide with reality, navigating dementia, decision making, and disputes in care planning, no worries. As you just saw me do, all sessions are being recorded, and the recordings will be posted and be available after the event on the North Carolina Serious Illness Coalition's website. It will take probably about a week or so, so it won't be instantaneous. And I think I saw Risa Hanau is joining us now, and she and Jonathan Williams did just an amazing session yesterday, and I'm seeing head nodding. It was really great. In terms of logistics, we ask that you keep your microphones muted, and for the best viewing, choose speaker view for Zoom. I will be spotlighting the different presenters, so you'll be able to see them, and I'm going to take this slide away in a moment, but that'll be the best way to see. For those who haven't already, do take a moment to introduce yourselves on the chat line. I know that was fun yesterday to see where everyone is coming from. While this is a North Carolina event, one of our presenters is in California, but also we had a number of folks joining us from DC and Wisconsin, and I lost some of the other states, but I'm so pleased that we had a number of colleagues across the state and across the nation join us. You can also use the chat throughout the session. I'll be paying attention to it. Our moderator, Dr. Bowen, will be paying attention to it a little bit, and Ellie Ward. So that way, if there are questions, the reason why we do this in regular, good old-fashioned Zoom as opposed to Zoom webinar is we do want to make this as engaging as possible, so that way you can see and share. So while we know today is going to be thought-provoking and so helpful, we also want to encourage you to attend tomorrow's closing session on We Are All in This Together, Caregiving in the U.S. 2025. For those of you, and I can see Karen and a number of us with the Caregiving Collaborative that geek out on good new data. Data was just released about North Carolina yesterday or 2 days ago. So we're so excited that not only is it going to be focusing on the caregiving in the US, brand new report, but literally hot off the press, we have a number of North Carolina insights to share. So please join us tomorrow. As for me, for those who don't know me, I am Heather Altman. I'm the Executive Director of the North Carolina Serious Illness Coalition. We are a statewide group of health professionals, providers, and caregivers focused on improving the lives of the seriously ill of all ages and their caregivers. Through collective action of our active work groups, we address clinical practice and quality, advanced care planning, caregiver and patient engagement, all through a variety of communication, advocacy, and education efforts. You are all welcome to join the coalition. If you are not already members, there is no cost to join. And so to learn more about the coalition, you can go to our website and you can see it you can see it behind me, www.ncsicoalition.org, or you can drop me a note in the chat and I'll be sure to add you to the listserv. Many thanks to so many coalition members for developing this symposium over the last few months. We also want to give a special thank you to the sponsors of our coalition and the symposium. I'm going to change a slide really quickly so you can see all of our sponsors. We are really proud that there's no cost to join the coalition, but we do have some costs. So we are especially grateful to our sponsors for helping us put on this event as well as others throughout the year. So in addition to highlighting our sponsors in general, I do want to give special recognition, and I'm going to go back to our, there we go, to our main page. just because we have a special sponsor. We have a session sponsor today, Carinova. And I do want to take a moment to invite Dean Higgins, Vice President of Health Transformation, to share some remarks. But Dean, don't do it yet, because what I want to do is spotlight your loveliness. All right. If you could just say a few words about Carinova, it'd be great. Thank you.
Thanks, Heather. And good afternoon. I almost say good morning, everyone. So pleased to be with everyone. And at Carinova is really pleased to also sponsor the Xerosomas Coalition and the virtual symposium. I'll be brief because I'm really excited about the presentation today and learning from this great lineup of speakers and panelists. But so Carinova, we're an independent nonprofit organization. We started as a joint initiative between both the North and South Carolina Healthcare and Hospital Associations, and also the Duke Endowment. So we were this idea came about 5 years ago. We are bringing together partners across the Carolinas that I would say that are eager to see transformation and innovation in healthcare. We see ourselves as a connector of people and ideas, and we're working with the provider community, payers, community health advocates, and patients to support promising new practices and develop business models that we can scale and sustain for systems change. So we our three main areas that we focus in, and we see these as our long-term portfolios. Obviously, serious illness, so we refer to that as transforming serious illness care. We're doing some innovative pilots across North and South Carolina with payers and providers to how do we develop new care models and then find a value-based payment to support those models long term. So having a lot of great traction and success in both states with those pilots. And then also just beyond the pilots, how do we support the provider community and developing and disseminating best practices around serious illness care? We're also focusing the improving mental wellness space. So working at the state levels in the Carolinas to help really to be that neutral convener of all the different players that are trying to improve the behavioral health system of care and prevention. And so also through that work, doing some innovative pilots, for example, looking at school-based mental wellness and how we work with school systems, and again, also the payment mechanisms related to those type of school-based pilots. And then our third portfolio right now is strengthening the healthcare workforce, and really that spans all of our areas, because if we think about care models and just the workforce that it takes to sustain those new care models, but then through an accelerator, working with health systems to develop and lift up those innovative practices that focus on retention and burnout. So really excited about the partnerships we have, and again, with the Serious Illness Coalition. So with that, I will turn it back over to Heather.
Oh, thank you so much, Dean. It's just amazing your partnership for the past 20 years, but now especially your leadership in the inclusion of Carinova has been really wonderful. And interestingly, when we were mentioning our states that are on here, you do so much not just in North Carolina, but in South Carolina as well. And a number of our South Carolina partners are on this call right now. So thank you for everything. It pains me to do this, but I'm removing your spotlight. There we go. You have been removed. And I'm now going to change the spotlights. It's just such a powerful thing, the ability to spotlight. And I'm now going to spotlight Dr. Gonzalez. I'm going to spotlight Dr. Fisher. And I'm going to spotlight Dr. Bowen. Oh, so powerful. I guess I'll spotlight me for just a quick second, and then I'm going to take myself out of the loop. All right. I'm really excited now to start today's session, Conversations That Count, Aligning Care with Goals for Every Patient. I do like to do shout out and love and honoring where possible. And so Ellie Ward, I know you are moving from your car into your office. I give so much credit to Ellie, our wonderful coalition member. A number of months ago, she shared some powerful articles and said, wouldn't it be fabulous if we could have the authors of these articles come on and do a symposium session? And then we sent out an email, and right away, Dr. Gonzalez and his team were on board. Dr. Fisher was on board, and Dr. Bowen, and just could not be more excited to talk about the important work in facilitating and documenting serious illness and goals of care conversations in the hospital. So with that, I want to really excited to have a fabulous moderator with us. I am in charge of doing brief introductions, so I want to give a warm welcome to Dr. Christina Bowen, our moderator. She is the Chief Wellbeing Officer at ECU Health. Dr. Bowen is a family medicine physician who has cared for communities across Eastern North Carolina for more than 15 years. She also has served as the medical director for the Dare County Department of Public Health, where her leadership earned her North Carolina's first Community Star Award. At ECU Health, Dr. Bowen leads innovative efforts to support team member and provider well-being, engagement, and equity, improving the health of both caregivers and the communities they serve. And I know from our conversation 10 minutes ago, after this symposium, she's ready to go to get these changes into ECU Health. So Dr. Gonzalez and Dr. Fisher, you have already made a huge impact on ECU Health, and you haven't even said a word yet. And so now as of our presenters, we are honored to have Dr. Matthew Gonzalez, Associate Vice President and Chief Medical and Operations Officer for Providence Health's Institute for Human Caring. That name in California, a fellowship-trained, board-certified palliative medicine physician. Dr. Gonzalez is a Cambia Health Foundation Sojourn Scholar and one of the Catholic Health Association's Tomorrow Leaders. I'm going to change that. You're a today leader, but fine. I'll let you have a tomorrow leader. He has a background in both software engineering, which is fascinating, and medicine, which allows him to bring a unique blend of innovation and compassion, advancing palliative care practices that focus on dignity, empathy, and high quality care for every patient. As the mother of an engineering student, I'm amazed and cannot wait for you to geek out on that with us. He's also one of the authors of the recently released New England Journal of Medicine article, which will be discussed successful strategies for operationalizing goals of care documentation. And finally, please welcome back to the North Carolina Serious Illness Coalition, really one of our founders, Dr. Jonathan Fisher, who was the chair of the original Serious Illness Serious Illness Task Force, led by the North Carolina Institute of Medicine that became the foundation for our coalition. He's super young, so it's weird to call him the grandfather of the Serious Illness Coalition, but let's do that. Dr. Fisher, besides taking care of starting us, is the medical director of palliative care for Duke Population Health and medical associate professor in the Department of Family Medicine and Community Health at Duke. Lots of other Duke titles, but we'll stop there. A family physician by training, Dr. Fisher devotes his clinical work to hospice and palliative care, helping patients manage difficult symptoms and supporting families through serious illness, and working with an interdisciplinary team. He focuses on what matters most to each person, aligning care with their goals and values. Also, over the last, I realized, Dr. Fisher, it's been 20 years, I think, since you and I first met and became friends. So I have seen firsthand how Dr. Fisher is known for his compassionate, inclusive approach to person-centered care. He also geeked out and wrote an article that we'll talk about, the article Goal Concordant Care, End of Life Planning Conversations for All Seriously Ill Patients. I will put links to both of those articles in the chat, but this is where I get to stop talking and turn it over to Dr. Bowen, and really thank you all so much for joining us.
Thank you, Heather. I just want to say thank you so much, Dr. Gonzalez and Dr. Fisher. Heather is not wrong. I read your articles and I was like, oh my gosh, this is exactly what we've been talking about at ECU Health for the last 6 months. So I can't wait to be able to share your incredible work with our partners back at ECU Health. So thank you for all you're doing for us in North Carolina, but I have no doubt that this is national, that you're helping us to be better when we talk about goals of care with patients. So I'm going to start with you, Dr. Gonzalez. And just as Heather mentioned, I just want to highlight again your article, which was in probably my favorite journal because it's really how are we innovating in healthcare, the New England Journal of Medicine Catalyst. And I know that was June 2025 when that came out. And again, that was Successful Strategies for Operationalizing Goals of Care Documentation. So I love it because the rubber hit the road And you showed us how we could come alongside and do this in our organization. So if you wouldn't mind, would you give us just a brief summary of your project, and an overview? And then I have so many questions. I'm going to try to keep it to 9 because it's so amazing and I can't wait to learn from both of you.
Thanks.
Thank you.
That's really kind of you. And I'm excited to be here with you all to be sharing a little bit of the work. And it has been a labor of love. So I want to start from a place of saying to those of you that may look at it and be excited about the outcomes. We are too. We're super excited about it. As many things though go, when you publish something, it doesn't include all of the like daily trials and tribulations that we all face in doing this work. And so I just want to say that from the start that like while we did some things right, we also had some challenges along the way. But we really at the Institute for Human Caring spent a lot of time trying to think about the best ways to be able to honor what matters to people when they're in the hospital, and really felt like back in 2015 when we started this project in earnest, that we as a health system could do a better job at having these conversations. And for those of you that don't know Providence, it's very West Coast, so we operate 52 hospitals, about 1,200 clinics, over 7 different states. It's all West Coast based. So Alaska, Washington, Montana, Oregon, California, Texas, New Mexico. And our idea was to say within our hospitals, and there's certainly more work to do in our clinics, but within our hospitals, could we increase the rate of goals of care conversations in the sickest of the sick? And for that, we chose a really sick population, patients who were in the ICU for 5 days or more, which those of you that do this care on a daily basis will know that it's pretty hard to argue that patients, or sometimes their families, often a lot of times their families, don't deserve and need a conversation about what's going on, what's meaningful in the context of their 5-day ICU stay. And so what we did really was to try to figure out how we could reduce the barriers for clinicians to have these conversations, and really identified a number of barriers that folks had, and spent years trying to really break down those barriers. Our impression wasn't that clinicians didn't want to have these conversations or didn't think they were important, but that the system around them made it really difficult to have these conversations. So a few things that we really focused on, one, leadership engagement, really making sure that the senior leadership of all of the hospitals were bought into this, had metrics in common that were tied to how the performance of this went, not to the outcome of the conversation, but whether to the conversation happened or not. So that included engaging the chief executive of every hospital, the CEO, the chief medical officer, the chief nursing officer. It included, as you said, Heather, geeking out a bit and like fixing Epic, because Epic is a good platform. It's a strong platform. When we started in 2015, it was much worse than it is now. And I'm not saying it's perfect, but we spent a lot of time trying to make it better. The other thing that we really did is we tried to build data-rich dashboards. So by optimizing Epic, then we could like pull information out really quickly and provide mirrors to people, really, of like, hey, this is how your performance is doing, and allow hospitals and clinical groups to almost compete against one another in terms of making sure that they were having these conversations as much as they thought they were. And I would say, you know, one of the things that we really focus on is like, for the last piece, which was a big piece for us, was training. Recognizing that it is really hard to have these conversations, and I'm very blessed to have completed a palliative care fellowship, which was I was good at these conversations before I did fellowship, but like that extra training in how to have these conversations well, and how to sit calmly when someone says, "Are you telling me I'm dying?" Those pieces of learning that, like, we really tried to operationalize a large scale training effort around having these conversations. Our first year in 2016, in 2 pilot hospitals, we had 1,200 or so conversations that had happened, these goals of care conversations. Just for reference, last year we had about 100,000 of them over the course of our entire enterprise. So all 52 hospitals. So a huge rise that I honestly like. I love my job, and there are some hard days in my job, but this, like, when you see these numbers and you recognize the work that we're able to help enable our clinicians to do, that's been the fun part.
That's incredible. Thank you so much. I took lots of notes that I personally want to ask you. I'm going to stay to my script of questions, but I have some I'm going to say. I love what you said about just a couple of things really quickly, and then I'll go into them. One of the things I love is that you said this is truly about honoring the patients. And I know that we talk a lot about that, but really highlighting that. So I'm curious. I went through your algorithm that you stated for the program. One of the things that you said that I do think I want to just go ahead and ask a question about is you, and I saw this in the article and I thought it was brilliant, is that you did tie it to senior leadership to their metrics. And so not only tying it to their metrics, you had to get them to buy in. So how did you explain to them the why and the importance of this from, and honoring the patient and excellent clinical care for these patients?
Yeah, it's such a great question. So I would say I can take some responsibility for that, but the other person, the person that really founded the Institute for Human Caring is Ira Byock. And those of you, I see a few head nods, know that he is a force to be reckoned with in our field. He's brilliant and inspiring, and a deep friend and mentor. I had a privilege of working side by side with Ira for 7.5 years between the time he founded the Institute and when he doesn't say retired anymore. He says JBC, jobless by choice, because he says that retirement's kind of tantamount to being dead in academic society. So he's now JBC, but Ira taught me a lot about aligning and engaging with people and being able to hear all of the barriers that exist and then working through that. For us, the tying of leadership around this and having senior leaders at the highest system levels of the organizations really supporting this also too was invaluable. So
I agree.
Just to be clear, the CEO, the CMO, the CNO, their annual at-risk compensation, so their bonus was tied to quality metrics.
I saw that in the paper.
Yeah.
That's what I wanted you to highlight.
Yeah. So, to be able to do, and that's like along with everything else, like the sepsis metrics that we all
all
think
the other
about,
metrics. That's
all
right.
of those pieces. And I want to be clear, it wasn't about outcome. It wasn't about trying to say like we were trying to reduce care or transition people from full code to DNR. It was simply whether a conversation happened.
Yes. Yeah. No, that's what I loved, is it was really, they're getting compensated and they're understanding why you need to have that connection with your patients and you need to have these documented. That was incredible in paper. So interesting. So what do you think was the biggest barrier? Because you talked about Epic. We use Epic at ECU Health. I'm a big fan as well, and partner with Informatics. What do you think the biggest barrier or obstacle to including that documentation into Epic was?
It's evolved over time because it's gotten better. But what I would say is the first biggest barrier is when we started this project, it wasn't easy to identify these conversations at all.
Right.
So our first step was to design like a standalone note, which is fine. It worked for a number of years. It worked for about 4 years. But the trouble is that like it's also frustrating as a clinician because you're double documenting everything.
Right.
I would do a palliative care consult and I'd have to write my consult note and I'd have to write a goals of care note. That's not efficient.
And that was kind of what I was thinking, is because one of the things in another hat, my well-being hat, is how do we decrease administrative burdens for our clinicians around documentation? And so what does that look like for you all? Because I know that was probably on your radar. We must have these documented. And so how do we come alongside our clinicians and make sure this is part of the EHR while not creating a lot of extra clicks and a lot of additional note writing?
Yeah, it's such this is like the constant problem that we all have in our lives, right? So in 2020 we moved from like the standalone note to a little tool that you could embed. You type .goc,
Yeah.
and
Yeah.
you can either ignore it or you can fill in a few details, and that means that it's like in your consult note, your progress note, whatever. As of October 7th, we've now transitioned to our third strategy here, which is
Okay.
that we're using GPT-4 embedded into Epic.
Yeah.
Which means that all of the notes written in a hospital are read by GPT in a private, secure way and
Mhm.
identifies whether that note has a goals of care conversation or not. So doctors have 0 clicks now to be able to figure out, nurses have 0 clicks, everybody in the hospital, 0 clicks to be able to identify whether that note has a goals of care conversation in it and highlight it to other parts of other clinicians.
So you're using AI to help you. That's brilliant. I love
Yeah.
that.
Well, I
Yeah.
got tired of teaching people.
Mhm.
Like, if someone comes from ECU or Advocate and comes to Providence, like they move across the country and they come here, it's exhausting to teach them. This
Mhm.
is the right way to input a goals of care conversation in a
Right.
medical system. And
Right.
so this allows us to get away from that. We can say, like, do
Gotcha.
your work, like whatever that looks like, and then we find it in the background.
I love that. So I feel like I would love to hear more about having having our clinicians be comfortable with these conversations. So I know that's something that in 2020 is really when we started ramping up actually healthcare worker well-being work at ECU Health. And one of the questions that nurses kept asking is and begging for was, I need education around talking to my patients and having end of life discussions. And so I give a huge shout out to Ellie Ward and to Dr. Fisher for all of the work they're helping us do at ECU Health around that. And so I really heard that education and skilling up clinicians was an essential component of your success. And so I'd love to hear a little bit more about that. And what do you think is like the minimum necessary for our clinicians to feel empowered to have these conversations?
Oh, minimum is such a hard answer for me.
I know that's a hard word. I know.
I don't know. I
You
so I
can tell
guess
me dream state and minimum. How about that?
um well, I think a fundamental skill that clinicians need to be better at is recognizing emotion and sitting with it.
Mm,
And so for us, that is something that we're trying to help people get better at. And it's interesting to me that, like, when you look at studies of doctors, I'll just focus on doctors because I know the research best, that like first year med students have higher empathy
oh yeah.
than attendings in independent ratings. It goes down with training, right? And so, like, fascinating that we in our training get rid of that over time. And so I think a lot of this is about, and I think that's true across all disciplines, is helping to increase that empathy and trying to allow people to respond better to emotions.
Mhm.
What I would say is we spend a lot of time training nurses. We actually, the majority of the folks, and we've trained, I've lost track, somewhere around 5,500 people over the last 6 years in Atul Gawande and Susan Black's Serious Illness Conversation Guide, which is not perfect by any means, but it is a strong outline for people in a short amount of time. We looked at a lot of other tools, but what we liked about it was that it was doable and scalable in a way that a large health system could do. And so a lot of that course was focused on not just the words of the guide and like this progression of how to have a conversation, but how to respond when somebody says, I'm scared of dying short of breath.
Yeah. So a couple of things. I love that you highlighted that about empathy. Recognizing emotion and being able to sit with it is truly hard. Um, and just what you said, it's interesting. This is not what we're talking about today. I think if we get better at these conversations as clinicians, it decreases our risk for burnout because there's very good data that when we connect with patients, it decreases our risk for burnout. So it actually supports healthcare worker well-being to be able to have these conversations and sit with that emotion. Um, so I love that you said that about our medical students because we live at ECU. I do. I work with medical students and residents, and I'm like, gosh, sometimes they're better at having these conversations than some of my partners, because they can sit with a really difficult emotion. So I love that you said that. Um, And
Dr.
then,
Bowen.
yeah,
Hey, it's Heather. I'm your moderator chat person. I did want to point out two really thoughtful questions have come from Julie Goldstein in the chat
yeah.
line, and I just wanted to make sure you saw them. The first is, do the AI identified goals of care notes populate a particular centralized spot in Epic? And then the second question was, were you able to engage the nurses with full several hour Ariadne course? And I think that connects to so one's more technical and one's more, so sorry to interrupt, but wanted to point
No,
that.
that's
No.
great. My fault is when I listen, I'm like totally locked in to Dr. Gonzalez and Dr. Fisher.
Well,
Like,
that is not bad that you are fully engaged.
It's
So
hard to
there
do a
you
lot of
go.
things at once. Yeah. Yeah, the AI notes plugs into the rest of our system. So it doesn't matter now which of our three techniques you use. If you use a standalone goals of care node, if you use this like drop-in.goals of care or AI, it all flows to the same place. I think our next step will try to be to summarize those using AI, but we've been very cautious about that because, as you know, AI can hallucinate. And so we've just felt like the best thing to do is to put those all in one collated place and allow clinicians to read them all and to make
mm,
decisions based off of that, kind of like rather than asking AI to summarize it and making a decision around that. So that's the first part. The second part is yes, in fact, we've had an easier time engaging nurses than physicians in this training. Um, we started out
no
with
surprise.
physicians, yeah, and like Ira and I, like we literally, I think we paid them something like $300 and brought them dinner, and we did it at night. Like Ira and I came in and did class at like 7 p.m. at night, and I remember it's just like a fundamental memory for me. Ira Bayak and I cleaning up other people's dishes at 10 p.m. after the course was over, and yet like when we engaged nurses, like there was a hunger and a need and a desire, and really for us, yes, the physicians were an important piece in having those conversations around prognosis, but our nursing colleagues were so good at process that like engaging the nurses in that conversation and having them and showing them and allowing them to have a part of that conversation was like super helpful in changing culture.
I think that was one of the things I took from the article that I think is vitally important is the interprofessional nature of which you allowed people to have these goals of care conversations. And I love that you expanded it and really it was, I think you said is it nurses, physicians, chaplains, who else, and social workers
Yeah.
that you said could all document. Is that right in the paper?
Yeah, absolutely. We even had some physical therapists come. And they're spending
Yeah,
a lot of time with folks, and there's functional needs that happen there. And I would say in some of our hospitals, that was a bit of a stretch. There were conversations that we needed to have,
right.
but ultimately, like we were able to come to a deep understanding that having these conversations isn't necessarily a responsibility of one discipline, and that all of us saying the right things or talking through this could only help. I mean, I do consults still for palliative care, and I can't tell you like it's so different now than it used to be, where you'd walk in and different people would be saying different things, right? Like the nurse says one thing,
Right.
the respiratory therapist says another, the physician says another. So of course the patient, if they're concerned, I'm not going to tell you that still doesn't happen in our health system because it does, but it happens less frequently because, for instance, one of the things nurses suggested was making sure that in reports that we include a nod about goals of care. And it used to be that we said, have goals of care been discussed? But now in our high contact environments like the ICU or step down units, they've changed the question from were goals of care discussed in this admission to what were the goals of care that were discussed this admission.
Right. I love that. So a few more minutes and then I'm going to jump over to Dr. Fisher. Um, what do you feel like have been the biggest benefits that you've seen in having your health system really document these goals of care? How have you seen that this has benefited the health system? It's got a really big health system.
Yeah. Um,
Or
so
patients, not just the
yeah,
health system.
I
You
think
know,
it's
like,
both.
yeah,
Yeah. I'll share a quick story, which is a few years ago, I was cross covering for a hospice team, and I got called at like I don't know, 10 o'clock at night on a Saturday. And they called about this patient who was admitted for something else, but had had a bad stroke in the hospital. Um, and the hospice team was saying, oh, his family's ready for hospice. Like this was unexpected, but we're gonna have him move towards hospice. And I will tell you that, like, you know, I don't mind cross covering hospice, but you always want to make sure you're doing the right thing in those situations. So I like
Yeah.
logged into Epic just to double check and look over the chart. And we'll say within 3 clicks, right, from like selecting the person, going to the storyboard on the left and clicking goals of care, and having it come up. I'd read a beautiful goals of care discussion by one of the floor nurses like 4 days
Wow.
before.
Yeah.
And it was all about how he was the captain of a Navy vessel for a long time, and how his independence and his ability to like roam the seas and be doing all of the like physical things that were important to him, that mattered most to him. And if those things couldn't happen, they were trade-offs that he wasn't willing to make in his life to continue it. So I can't tell you the amount of confidence it gave me to like sign the hospice admission orders that night,
Yeah.
or even like the next morning when I went back in and saw his like Navy captain's hat on the bedside table, to be able to say to his daughters, like, oh, I know that mattered.
Mm.
And like to find that information without searching for it, I think that that's happening way more often than it was.
Yeah. So wow. You're really seeing how you're on. I mean, you're honoring that your health system is honoring them as a human, like in their legacy. I mean, that's
We
incredible.
aim to. We're
That's
no
an incredible
by no means
story.
perfect, right? There's no panacea here
Well,
on the
I mean,
West Coast, but
we know
it is. We
we're
are
all going to
on the
want to come
journey.
there.
Yeah, we're on the journey, and it's been a great journey to be on. But like I said, there's been real challenges and some hard conversations that we've had with leaders over time. But it's been
Yeah.
helpful.
So quickly, I have 2 more questions. One thing I think that is I'm curious, have you all looked to see how this has impacted your patient experience surveys?
Yeah. So it's variable, is what I would say, and in hospitals that we've been doing this the longest, we see signals in the data around this with serious illness. So they're more likely in 14 different domains on Press Ganey surveys to be able to, for instance, select the hospital in top box more often,
Right.
to respond to nurses treated me with respect in top box. So we see signals across the whole health system. We're not there yet, and I think it's partly because of the variability of the health system. I think it's partly, frankly, some of our hospitals in rural geographies like Alaska, to be honest, is still recovering from COVID and like all of the implications that happened up there. So it's variable, but in places that we've been doing this a long time, certainly we see an improvement in those scores, which is not surprising. I mean,
No, I know. I mean, I asked it, it was kind of like,
Yeah.
it's a rhetorical question, but I think it's really interesting as we're going into fiscal year 26. We use Press Ganey for experience surveys as well. And staff work together to care for you, is the key driver for patient experience surveys. And so I can't help but think, wow, it would be really interesting, because what I feel is that's exactly what you all have implemented. It's just incredible. My last question, do you think that goals of care documentation and care alignment should be a quality metric for all health systems? And
I
why
do.
or why not?
I do. And I think that's, for some leaders, that's going to be hard. One encouragement that I would say, if folks are having trouble with this piece of the conversation, is to try to leverage the new CMS inpatient quality reporting age-friendly health system measures. There's 5 of them. They're just pay for reporting right now, not pay for performance. But the expectation is they will become pay for performance. And part of that is making sure that conversations around what matters to people get recorded, those older than 65, and that's a CMS reported measure that your hospital, if it's participating, which almost everyone is, right? They have to report on in the spring for what happened this year. So what I would see is, like, we've been drafting off of that to get increasing pull in some of the places that we've had some challenges. The other place that we are continuing to grow in is that we've mostly done our work hospital based. But we're bridging into the outpatient space, because the truth is, if your first conversation around what's meaningful in your life is in the ICU after 5 days, we have missed the mark.
Right. I love that. So you're moving, so that you're reaching out now into the ambulatory world as well.
Yeah.
Love it. That's great. Well, thank you so much. We're now going to open the floor to Dr. Fisher, and then we are going to have time at the end, everyone, for questions, because I know probably everybody, I cannot see the chat. So Heather, if there's a burning question, please let me know. Thank you, Dr. Gonzalez. Dr. Fisher, we are excited for you to get to tell us. I'm going to highlight your article. I know that Heather's already said it, but Goal Concordant Care, End of Life Planning Conversations for All Seriously Ill Patients. That also was highlighted in the New England Journal of Medicine Catalyst in 2022. Would you mind giving us a brief summary of your project?
Absolutely. Thanks for having me. And I really enjoyed listening to you, Matthew. And I imagine there's a lot of granular stuff we could talk about. I think there's probably more in similarity with our approaches to this than there are differences, although I think there are a few differences that I'd want to highlight. In general, there's some kind of steady, important approaches, like identifying who's the patient population you're trying to reach out to, right? So you heard Dr. Gonzalez talk about they were looking for people to have conversations in the ICU within 5 days of being there. We worked instead to develop a denominator population of people that had, say, like 10 different conditions based on ICD codes, right? And we workshop this with like 150 different providers across our health system to try and identify who would be the people that are most important to have these goals of care conversations with, right? So that's probably a little bit more upstream population than what Dr. Gonzalez we're targeting. Let me also point out that Duke, we're 3 hospitals, okay? Not 50 plus hospitals, right? So it's a much smaller entity.
Right.
Our sandbox is definitely a little smaller. The other thing I'll point out right from the top is that I think Providence got leadership buy-in in a way that I still am having a hard time with at Duke. Okay.
Right.
I think
Yeah.
that really is a key difference. When you look at what is it that goes into changing provider behavior, okay?
Yeah.
And this is true whether it's physicians or advanced practice providers, PAs, nurses, et cetera, right? We know to a degree, there's training, right? People need to know how to do a certain skill. And this is whether you're going to be ordering mammograms, colonoscopies, flu shots, or doing goals of care conversations. If you want to change provider behavior, right, people need to know what it is they're being asked to do. They need to get feedback about how they're doing, right? So we also developed a dashboard that you could drill down by unit, by provider, see how somebody's doing in terms of what percentage of their patients have had goals of care conversations of that denominator population, right? And we were specifically interested that the folks who have died, and we pulled in decedent data, that they've had one of those conversations in the last 6 months of life, okay? And I can circle back to that. But so you want to give people an opportunity to get data. Physicians in particular want to do better than their peers, or at least as well as their peers. So what you saw in both of our systems is that you could find out, how am I doing relative to my peers, right?
Yeah, right.
But the last thing, so shaming them really is a powerful tool, okay? And then the last thing is incentivizing somebody for the behavior, okay? So whether you're paying them directly for this, making it part of their bonus pay, or I have even said that just having leadership messaging saying, hey, this is really important to us, so get on board with this, right? And if you were to dig down into our data and look at the groups that outperformed others, it was really the palliative care group and the hospitalists. So 2 groups that incorporated incentivizing into this process.
Right.
So, and I don't want to go into the politics of why I haven't been able to move our C-suite on this, and some of it is internal, some of it is timing, some of it is like, all right, we've got too many things going on in the health system right now, they can't hear this other thing, and wah, 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 wah. Okay.
Right.
So it's an ongoing challenge, and you know, as my my experience accumulates, my patience for that wears down. So we'll see. I'll probably get a little bit more rowdy, a little more pushy as time goes on. So we identified patients. We also came up with templates for how to do these notes. Something that we worked with Epic to develop also are these bookends. I'm not sure that Matthew's using those now. Basically, it's saying, okay, I'm in my note, I'm doing my consult note. Now I'm getting to the part that's around goals of care. I can just type in .acp begin, and I write my goals of care note. And at the end of it, I write .acp end, and it will copy and paste everything in between those two bookends into what we call our ACP tab, right? So we have a centralized place where all goals of care notes can go. You can go directly into the ACP tab and write a note, or you can write it from within your other documentation. We haven't employed AI to find those hidden ACP notes or goals of care notes in other people's documentation, but I assume we could try something like that too. And then, so then what's nice is on the storyboard, on a patient storyboard, you can see it says right underneath their code status, it'll say, you know, ACP. And if there's a note that's been either uploaded, like a scanned document, like a MOST form or a healthcare power of attorney, or anyone has written a note in there, it changes color. So you know that there's something there. You can hover over it and it will pull up a hyperlink to any of the notes that have been written. So again, you can very quickly see what's been entered into that ACP tab. So that kind of documentation efficiency. We worked to pull in the death data from a number of sources to try and use that as a metric of like, okay, we think that people in their last 6 months of life should at least have had an opportunity. Now, of course, you're not going to get everybody. There are traumas or unexpected deaths, but at least for the folks that have a serious illness for some prolonged period of time, there should be enough warning to do that. And then, of course, there's the training. And to this day, I still lean on a number of different models simultaneously, whether it's Ariadne Labs, you know, Serious Illness Guide, or VitalTalk. And I think I alter the formats, whether I'm doing something, you know, in a series of hour-long conversation or teaching sessions, or 2 hours, or half day, or full day, or even a day and a half, which is what I spend with our palliative care fellows, right? So it's I utilize the time that I'm given, right? And will alter the format depending upon who it is that I'm teaching. I have a little bit of a bias. I tend to think that the Serious Illness Guide is a great, easy structure on-ramp for people that are completely unfamiliar with, all right, what does this conversation look like? What should I be asking? You know, it was developed by Atul Gawande and others. And remember, he wrote the checklist theory. So it was basically his checklist approach to these conversations, right? Okay, what's the parts that we need to do? What I was a little put off by is after you share the prognostic information, it's like, respond to the emotions. Okay, and then it goes on, right? Asking, you know, people about what's most important to them. I'm like, okay, right? And you've just heard from Dr. Gonzalez, and I would.
That's the hardest part.
That is the hardest part.
Yeah.
Right? If you're going to teach anybody anything, is like how to recognize an emotional cue, right?
Yeah.
How to respond to it, right? With empathy. So, look, I've done a lot of work with Ariadne, and I love what they're doing, and I'm sure if we gave, you know, Dr. Gonzalez more opportunity to talk about it, he would tell me how they overcame that part, what they added into their teaching, right? Because I know that there's a lot of VitalTalk teachers out there in Providence as well, and that they incorporate, you know, some of that emotion. I will say that not just recognizing emotion, what's the pitfall that most clinicians fall into? The further along in their training they go, the more they know, the more questions are going to sound like asks for information. What do you mean that didn't work? Wait a minute, what are we going to do about this? Right? So they'll miss the affective component of that question and go right to the answer. right? So that's why med students are so good at being empathetic, because they don't know anything. They don't know the answer, right?
Right.
So, but the more you learn, and nurses are not immune to this, right? They want to fix, they want to educate, and they figure, oh, if I answer the question, this person's going to feel better. It
Yeah.
doesn't work that way, right?
Right.
And what's the harm in missing the emotion, right? Well, first of all, if somebody's in an emotional state, they're not even going to hear the cognitive information you're sharing. It's right. It's like the Peanuts cartoons with the teacher in the background going wah 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 wah, right? They're not going to hear it, right? So you're wasting your breath. So when I get consulted by the ICU and they're telling me the team's not, the family's not getting it, right? What goes through my mind is, well, probably because you keep trying to explain it to them when they're in an emotional state. I don't say that, but I think that. So the first is they're not going to understand what you're saying to them if you don't recognize the emotion, right? Secondly, there's data behind the emotion, right? What the person's hoping for or worried about, which ultimately are going to be the pillars of your plan. So unless you use those empathetic continuers, right? That the NURSE acronym that we sometimes teach about different ways to respond to emotion, it's almost an advanced form of history taking. You're not going to unroof that emotion, see what's behind it. When someone says, you know, wait, why didn't that work? And I say, yeah, you know, I can imagine that's really unsettling and scary that it didn't work. They say, yeah, how am I going to tell my wife? Bingo. All right. That's one of the elements of the plan, right? I've got to help them talk with their family members about this. So, but you're not going to get at that stuff unless you have the skills to respond to that emotion, right? And then lastly, what I've kind of added to my teaching in the last few years, if you're the patient or family you're talking to are under the impression, either because of prior experiences or historical experiences, that someone who looks like me, because of the color of my skin, we're not going to get equitable care. We're not going to be treated as well. We're not going to be listened to, right? And now you're missing the emotion that they're sharing with you. What kind of experience are they having? They're going to be feeling dismissed, right? You're going only to reinforce the idea that you're not delivering equitable care. So rather than saying, oh, it's the patient or family's fault because they don't trust the system, we have to present ourselves as trustworthy. So recognizing emotion, being able to respond to that is part of delivering equitable care. That's my soapbox, okay? So I've really leaned hard into the Vital Talk model. And even when I've broken it down into its constituent parts of, all right, how do you share news, right? How do you construct a headline? How do you respond to emotion, right? How do you explore values, right? I really make sure that, or when I'm teaching nurses the difference between hospice and palliative care, I'm going to teach them the language. All right, how do I talk about palliative care with my patients? And what to expect, what emotional responses to expect, and how to respond to those, right? So a lot of training, altering the format. We even pushed out a new format called what we call a PING, which is a patient-initiated note of goals. So it's something that goes through the patient portal, what Epic called MyChart, right? So,
Yeah.
so a patient can fill out essentially the series of questions that the Serious Illness Conversation Guide asks them, right? And, you know, what are they hoping for? What are they worried about? What abilities are so important to them, right? How much are they willing to go through? These kinds of things. And they can fill that out in advance of a visit and discuss that further with their providers, right? Or if I'm an outpatient provider and I'm like, hey, I want you to be between now and the next time I see you, I want you to look at this PING and fill that out so that it's something we can talk about, right? One of my colleagues called me a recovering primary care doc, right? So I did primary care for 15 years before moving into hospice and palliative care. So I'm still totally committed to my colleagues doing primary care or outpatient care. How do you take care of patients with serious illness, right? In an efficiency-driven environment, right? How do you have these empathy-based conversations in an efficiency-driven environment, right? Yep. I once told Diane Meyer, and I gave her permission to steal this from me, that the reason I moved from primary care into palliative care is because I realized I had become trapped in a world increasingly focused on efficiency. And when I landed in palliative care, I found a world that was focused on empathy. And I knew that I had not gone into medicine to be efficient. So, but how do we help those clinicians that are still in that environment, right? And so one of the ways is by letting them have these conversations over a period of time, using the interprofessional team, right? Letting other people, whether they're population health nurses or other folks, introduce these conversations, have some of the values explorations with the social worker down the hall. Use your team and give patients homework to prepare. So you hear that we've all identified patients, came up with documentation tools. We included a BPA, which is a best practice advisory. Like it's something that's a pop-up that says, hey, this patient who meets our criteria hasn't had a goals of care conversations in the hospital, we say 6 months, outpatient, we say a year. And that way the provider sees that, right? They don't have to do anything about it, but it just lets them know. It's that tap on the shoulder that says, hey, this person could use that conversation. So I'll pause there and let you drill away with some questions.
Gosh, so much.
Dr. Bowen, is it okay if I jump in with a question from the chat line?
Of course it's okay.
Great.
You give me time because I'm like, I now have 10 of my own questions,
I know.
not even the scheduled
I got
questions.
your back,
Yeah.
friend. But Dr. Fisher, when you were talking about the issue around trust and the issue around acknowledging the inequities and systemic issues, there was a question that Marasat Hassan asked, and it's a good question for both of you. And I held off asking it, and then you did a great segue, which is, how are you incorporating the cultural and spiritual complexities in the training with helping staff sit with the emotions of their patients and caregivers? And I would add to that what you just said, and acknowledging the lack of trust that many already feel in the system. So you can speak to that.
So what I will say, there's a lot of things that we're not teaching in these trainings, right? And I mean, there's the whole component of like, what's your own reaction, right? What are you bringing into the room when you come in there? And how do you self-regulate, right? And recognize when, you're being triggered for some reason. And, this person reminds you of your grandmother or your aunt or the daughter, the sister-in-law who you can't stand or whatever. It's like, so, but with respect to the cultural and spiritual complexities, it comes up to some degree. For example, one of the challenges that, we're down the Bible Belt, right? So one of the challenges that comes up a lot in our conversations are expressions of faith. And, now, not everybody brings up faith in the same context. Sometimes it's kind of a little weaponization of faith to not talk about things, but oftentimes it's just a genuine expression of hope and so being able to teach people, all right, how do I respond when someone starts talking about a miracle, right? And how do and so you can explore that. Tell me what that would look like, right? Help me understand what that would look like, right? And offering a respect or praising statement. It sounds like your faith is an important source of support for you, right?
Mm-hmm.
And then something that we steal from the improv world, this yes and approach. Yes, we're also hoping for that miracle. And what else would be important to your dad while we're giving space and time for that miracle to happen, right?
Mm-hmm.
So it's not yes, but, right? Yeah, I hear what you're saying, but we got to look at the medical reality. It's yes and, right? So a lot of it's just being humble, recognizing that everybody has different values, everybody has different priorities. A patient may tell me that the most important thing for him is to be able to hit the remote on the TV and eat his pork skins, and everything else doesn't matter, right?
Mm-hmm.
It's like, I just need to be able to hear that and make sure that I'm recognizing that as I'm developing a plan.
Mm-hmm.
So I think it's within the context of humility and being able to hear what's important to somebody and being able to respond to that and recognize that. I think that's the tools that we give to folks for managing cultural and spiritual complexities. I'll give one example. I was standing outside of a room of a woman that just had a devastating stroke, and the adult son catches me and says, "You can't tell mom that she had a stroke." Like, okay. So, of course, I'm like, tell me more about that. Help me understand what's your concern, right? And he said, oh, she's going to give up hope. She's not going to, and then she's just going to die if she knows that she's really devastated from this. And eventually, and so this was a South Asian family, right? And eventually I was able to negotiate with him, like, would it be okay if we talked with your mom and asked her, how much information about what's going on with her and what might happen does she want to know? And he was able to agree to that, right? And of course, so when I went in and asked the patient, so, tell me what you know about what's going on. I don't know, tell me how much information you'd like to know. And she's like, oh, you can tell my son. I don't need to know. I was like, okay, awesome, right? So at least we're all on the same page, and I can feel confident about who I'm talking to about what, right? But at least from an initial moment, I was not contesting what this person was telling me, right? What the son was telling me, right? And it likely was in line with some of his, cultural upbringing, right? That the adult kids were going to be managing their parents' care. And that was perfectly normal for them and acceptable. And so just being prepared to hear that and roll with that and understand that, I think that's the key.
Dr. Gonzalez, will turn it over to you, but I do feel like there's a moment of levity here when the doctor asked my mom, what would she like to know years ago? And she goes, how do I get some chocolate pudding? And he goes, this is, she said to the visit, he goes, do you want to know anything that's happening to your care or your situation? She was in the hospital and she goes, yeah, how do I get chocolate pudding? I don't want to know anything else. So, all right, Dr. Gonzalez, for you.
I really agree with Dr. Fisher. There's a lot of things that we can't cover in these classes. We do the best we can to provide an introduction, but it is an introduction. Despite the fact that we've rebranded our courses 6 years ago now as advanced communication training, it turns out doctors, nurses do not want to sign up for basic communication training, which is a lot of what this is. And so just like playing to how their own egos was really important in getting
Words
folks
matter.
in the room. Yeah, they really matter.
Yep.
We spent a lot of time, not a lot, but like thinking around this idea of like being curious, and using that skill and teaching and honing in on that skill around like whether it's someone's goals or cultural preferences or spiritual beliefs. That like, I mean, I often think about like if I used to love to travel when I was younger. I mean, I still do, but I don't have as much time as I used to. But like if I was in a terrible car accident, when I was in Bhutan a few years ago, and I wasn't, but like if I was, I could just imagine if like someone pulled out one of those old school handbooks that we used to have around like and flipped to the page that's like Americans, they believe all of this. And like that's just not the way the real world works. There's some general principles I'm sure that we can all take from it, but we've really tried to lean into the fact that like none of us wants to be stereotyped or put into a box. And so the most important thing that we can do is bring our authentic selves and curiosity to that moment and trying to understand who the human being is across from us. I loved your example of like talking to the son and trying to understand what was meaningful. And like, it's just that's a lot of where we lean in. The other thing that we've like really talked about is that like, you're not alone in this. If you get into a situation, which is probably 20% of these conversations, where you're like, I don't know what to do. That's why we have specialty palliative care. That's why we have interdisciplinary teams that can come and help and think this through. It's so important. I remember years ago, even on my specialty palliative care team, I ran into a trouble. Like I could not progress a conversation. There was just like no openness. Our team chaplain on our palliative care team, Stephanie, went to see the person and came back and was like, she's ready to talk to you. And I was like, what did you do? And she's like, well, she's a Calvinist and her perspective of God at the end of life is like totally different than what yours is. And you need to approach this in a totally different way. And I was like, that's magic. I don't know what you did, which is often what people say about palliative care. But I think the recognition that like one human being doesn't have to answer all of these things is another piece that we try to incorporate into our training, and that like we're all different humans, and sometimes it requires different humans and different disciplines in order to like recognize who someone is and who the family is really important.
But so Heather, I think we're going to open up for questions. I just want to, one question that I want for both of you all that I feel like has just been resounding over what you've both said is that there's really a need for us to be able to listen. And it's funny that you said curiosity, Dr. Gonzalez, because that's what I wrote. How do we listen? How do we teach to listen with curiosity and to sit with these emotions? And really what keeps coming back to me is you're really helping us to understand. And that's where I want you to tell me, like, what is the minimum training that you feel like that you bring clinicians? And I think this is for everybody back to this is about being with people. To your point, Dr. Fisher, it is not about doing. When they're asking questions, like you so graciously shared, like, what are we going to do next? And you say, well, this is what we're going to do. We're going to give you antibiotics. We're going to do this. You're totally missing it. So, how do we teach these people that we've been trained? I mean, I'm a physician, like we've been trained to do things really well. So how do you, in these short snippets of advanced communication or your training at Duke, teach that skill of listening with curiosity and really being with people in these emotional conversations?
So the format I like to use as much as possible is using actors, right? Using simulations. Because I think you just learn more by trying the words yourself and seeing how they land, right? In
Role play.
role play, absolutely.
Okay. Yeah.
Facilitated role play wherever possible, right?
Mm-hmm.
That way you get those magical moments of you reach a stuck point, you brainstorm about how you might try something different, you try it differently, and you see how it yields a different outcome, right? And so that's the magic there. You know, when the patient is coming at you, you know, with anger, you know, like, do you even know what you're doing, right? Like being able to, you know, the learner calls timeout, right? Because they're like, I don't know what do I do here. So giving them the opportunity to step back into those moments and try out a new skill with a playful attitude. Like, let's just
Right.
let's just see how it goes, right?
Yeah. Right.
Experience that change. I think that's really the magic of the teaching happens. And I can't tell you how many clinicians, when I introduce this idea of that not all cognitive sounding questions need to be answered right away, right? And maybe before you answer a question that you ask permission, like, would it help if I shared with you why I'm suggesting this, right? Or would it help if I explained why we're suggesting this medicine? Is now a good time to talk about next steps, right? That power of permission, what
Yeah.
does it do? It gives agency to the patient, but more important for the clinician, you're taking their emotional temperature.
Yeah.
You're finding out, are they ready to move forward? And if you get anything other than a yes, then you know that that patient or family is still in what one of my colleagues called emotion land, America's least favorite amusement park, right? If they're still in emotion land, right, then you can't move forward. You got to stay in that
You
place.
got to stay in it. Mm-hmm.
Right. You know, we've talked about a lot today. I can see this is overwhelming. You know, maybe I
Mm-hmm.
need to give you a little more time. Maybe we should call our chaplain. Maybe you want to go home and talk to your husband. Whatever. You need to have your exit strategy because you're not going to get much further in that conversation. So as much as we can do it with live opportunities, the better. And, you know, getting people just to try out new skills, try saying words differently than they've said before, and getting them comfortable with situations that were previously foreign or uncomfortable to them.
Yeah. How about you, Dr. Gonzalez?
I
I heard
couldn't
about
agree
it.
more.
It sounded like a 2 or 3 hour when you were cleaning
Yeah.
dishes at 10 o'clock and it started at 7. So I want to
Yes.
hear about, wow, how are you getting that all accomplished? Tell us.
So we moved to some bit of online modules through COVID.
Yeah.
But we still do some occasional in-person classes. Typically, Our classes have been 2.5 hours in nature. It's about a 40-minute didactic, followed by about a 20-minute video of a good conversation,
Okay.
then an hour of role play, which is critical, and then a half an hour of debrief and how to input things to Epic. The hour of role play is really critical. We usually do 3 cases. The first one's super easy. We let people fly through that one because we want them to gain some confidence. The second one's a little harder. The third one's really hard. What I would say is the real magic happens in the room somewhere between like second and third case, where people hit their real learning edge because we're amping up the difficulty level.
Mhm.
And then they really engage with the content. A few years ago I was teaching this course, and one of them we were like previewing as like a person with short of breath, and we're talking about like what do you say if someone says to you, God, I'm scared of dying short of breath. He stopped me in the course and he said, yeah, but seriously, what do you say to that? Like, I just had this happen last week when I was on the floor. And he said, all that I could think of to say was, I'm going to go get you some oxygen tubing. And so he ran out of the room and he said, look, I know that wasn't the right thing to do, but I didn't know what else to do. I didn't know what other tools
Know
that
what
I
else to
had to
say.
do it with.
Mhm.
And so I asked him a question. I said to him, I said, if your mom said that to you, what do you think you would say? Sometimes I think it's a matter of like taking people out of their clinical brains and like putting them into their human brains, of recognizing that like, yeah, like living into their heart a bit and recognizing that like if it was your mom, your partner,
Yeah.
whatever, like it is, it's that's the magic that can happen. And but role playing that is deeply important. You can't teach that in a class. People have to come up against that. I will tell you that though we're having trouble scaling role play, because it's so time intense and so intensive, or so expensive. I'm proud we've trained 5,500 people. We have 25,000 doctors in our system and 35,000 nurses. Like the scale problem
Right.
for us is a real one. So we have been
Sure.
working over the past year and a half, and we're real close to testing at our health system. You can tell I'm a nerd in this, Heather. We've been testing an AI-based role play tool that has
This
AI
is fabulous that I love that you're
Yes.
bringing this online. This is
Yeah,
huge. Yeah.
right. So that like it's called Empathy AI. It's got 4
Yeah.
patients that you can interact with, all under the watchful gaze of like an AI communication coach, that if you get stuck and you don't know what to do, you like ask it for help and it tells you like, hey, here's what I would say next, and then gives you a score report at the end so that you can continually work on your skills. What we've heard from folks that's been really interesting is they feel more comfortable doing role play in this way.
They're
And
more comfortable utilizing
yeah,
that tool.
because
Yeah.
they're less embarrassed in front of a computer, which I find interesting. Now we'll have to see if the learning's durable. We're still really testing it. Like we're putting it
Yeah.
through the ropes. Like we're not close to releasing it externally because we're like, well, we maybe sometime within the next year, but like we're really trying to get it to a place where we feel confident, and still reviewing 100% of the transcripts around that, because we don't want to teach people bad skills, but
Yeah.
I think it's an interesting potential application of it.
Yeah.
I'm glad you mentioned that, because that was one of the questions. And then
Yep.
there's a whole other question, but let's stay on a different topic. But staying on this, Julie Goldstein did say we're struggling with the prospect of scaling role plays across our many hospitals. There's not enough facilitators. Is anyone experimenting with AI supported role plays that could be done independently? So Dr. Gonzalez, you shared yes. And then Dr. Fisher, I don't know if you want to talk more about it, but you did write that some Duke students have created an AI patient for some basic conversations, and you're hoping to work with them to expand it for more complicated conversations. I will say that I've gone through, Ellie allowed me to sit through one of the Vital Talks training, and even as theatrical as I can be and comfortable, role playing is not that comfortable. Like it just feels, I mean, I did it and it's abstract. So I'm definitely one of the people that I think would enjoy finding what's an authentic, like what feels genuine and practiced with a computer, that I don't feel judging my performance. That said, role plays do really help, but I could see myself enjoying the AI. Dr. Fisher, did you want to say more about the Duke students?
There's so interesting. I just see that Julie put in Legacy, and I'm actually doing a pilot with Legacy right now, and that's more of a right? At least the product that I'm working with is more of a conversation coach. So it listens to a clinician having that conversation, helps to generate the note, which is being done, is more ubiquitous at this point, but then also gives feedback to the clinician about what they did well, what they might do for subsequent conversations. And so I'm helping them to develop, all right, what is that feedback that you would give, to the clinician? So there's some work going on there. One of my colleagues teaches the first and second year medical school course around kind of introduction to clinical care, basic communication skills. And so I was talking to her about trying to expand some of what they're doing. But we ran into the challenge of like, all right, if there's not funds for actors and simulation, like how do we do that? And then she mentioned to me that some of her students had created this AI patient for delivering serious news, right? Or delivering bad news. And I was like, oh, that's awesome. And so she put me in touch with them. And we've had some preliminary conversations about what it would look like to expand that library of what this patient could, what these patients could look like. And so for people to have more practice. So it's a work in progress. I'm sure, as you hear Dr. Gonzalez, his group is working on it. There's probably other groups that are also trying to advance this type of work. So I think we'll begin to see more and more of these examples in the year ahead.
Yeah, I think so. The challenge for us, what I would say is, we had a pretty good working prototype a year ago, but like it's AI, if you've interacted with it, it's overly nice in every situation. Right? So like I could be like, Brandy, you're the worst patient on earth ever. I don't know why you're asking this question. And it would say, oh, you're right, doctor. I am. I'm so sorry. Like, what can I do to make your life better? And so like, it was a real challenge with our AI patients actually to get them to respond appropriately when people are not doing these conversations well. And so that was a real challenge, but it's been a fascinating experience.
So I'm going to change gears a little bit, and we have a few minutes left. And Melissa Corsi, I did see your comment about having people be comfortable with something I'm incredibly uncomfortable with, and that is silence. Not a fan of it, and it's something that I'm working on personally and with my clients. So in that vein, I'm not going to be silent, but yeah, it is a skill and one that at 55 I'm just still struggling with. But okay, so Carolyn Dowdy, I want to move it to the caregiver experience. We do have a number of folks, Carolyn, Karen, myself, who are really active in caregiver issues. We run the Caregiving Collaborative and work with caregivers every day. And many of us are deeply intense, our caregivers ourselves. And so Carolyn asked, I saw a study that by following the family or primary caregiver's self-care, up to 6 months reduce depression in the caregiver. Are systems implementing these types of follow-up care and educating caregivers on dismissal? I know when my husband had the stroke and aphasia, I wasn't, and it's devastating when you don't know what to expect or how to deal with their situation. So I think this speaks to how do you work with caregivers, how do you follow them over time, and how do you include them?
Oh, there's so much more work to do. I wish I had a great answer to that, honestly. It's been on our wish list for a long time at the Institute for Human Caring to figure out how we move into that space. I'll highlight two things that are really kind of poignant and interesting that we're using to generate more executive buy-in around it. The first is the National Academy of Science, Engineering, and Medicine back in June hosted a workshop on caregiving in their DC offices. It was really powerful and important, and just talked through the individual struggles and also the financial cost of caregiving that's uncompensated across this country. It's something like $6 billion of care that's being cared for by everyday people that are not being recognized. The other, which is playing really well in this because it's shorter, I think, is it's called Caregiving. It was done by Bradley Cooper, who took care of his own dad.
Yep.
And I think that that's been really lovely at highlighting the strain and the work that's being done. So we haven't done much, but we're using those to generate interest within our health system amongst leaders, which has always been our first step around like, how do we tell the human side of this story in a more clear way so that our CEO, so that our CMO of the entire health system recognize like, yeah, we really need to invest in this. So I don't have an answer right now, but trying to build interest.
Dr. Fisher, is there anything you want to share about caregiving before I do a commercial for tomorrow?
I think it's the linchpin to the redesign of our health systems. I talk about it as a Copernican revolution, right? Like we've built health systems that revolve around hospitals, where we actually need to be building systems that revolve around patients. And if you started to look at what is going on for a patient, who's in the closest orbit, right? It's the caregiver. So now you're really beginning to see where the issues are. So I think there's a lot more that can be done around caregiving. What's the pain point that I see every day that I'm in the hospital? Some of the hardest conversations I have with families is about the gaps in our payment structures, right? When a patient's debility begins to exceed the family's ability, right? Either they can't care for them, they're not wealthy enough to hire more people in the home, they're not poor enough to have Medicaid to pay for room and board in a facility, right? So it's that large swath of people in the middle that we don't have an answer for. So other than a few states that are trying to do something around this, that's a major gap in care. So when I'm talking to a family, it's one thing that I have to talk to them about some terrible disease that has befallen their loved one. It's another when I have to try and explain to them the human-made problem of the policies that don't match what their family's needs are. So, try imagine having that conversation when you walk into a room and Fox News is blaring on the television. And, it's all I can do to keep myself from sharing the political reality of, oh yeah, there were two candidates, one who had a plan for rectifying this, and we elected the other one, but never mind, we won't go there.
It is well, you all just did a nice that question. I didn't mean this to be, but this is so much of what we do with the North Carolina Serious Illness Coalition, but specifically with our patient and caregiver engagement and the North Carolina Caregiving Collaborative, which is a separate group but connected. So if any of you all, this is what we talk about all the time. I'm looking at our fearless co-leader, Karen Appert. Please and join us tomorrow for the discussion all about caregiving, and we are all in this together. Caregiving in the U.S. 2025. I want to do a quick thing. I want to reach out. I know we have just a few minutes left. Our wonderful graduate student, Katalia Alexander. This is probably a great time for Katalia to put the link in for the evaluation for today's session. We want to grab your attention so you can click on it and give your thoughts. But I want to, I did the shout out for tomorrow, but I want to hand it back over to Dr. Bowen to see if you have either final comments as well as final questions for our guests, our fabulous presenters.
I know they're amazing. And this has just been such a rich conversation. I think I don't have any, if I want to open it up before I do my closing comments, I think that I want to make sure, are there any other questions from anybody that's joining us today in this conversation? I feel like this has been such a rich dialogue. I want to open it up to make sure. Dr. Fisher and Dr. Gonzalez, you have two experts. So who else has a question before we do closing comments?
Okay, we're getting great job. Love the symposium, learned so much. In the aforementioned comment where I don't love silence, while you're thinking of your questions or any last comments, I did want to share. I did geek out a tiny bit with our chat, and Dr. Gonzalez may not recognize some of the names of the chat. Dr. Fisher, you may, but you've been busy presenting. Just in our group alone, the participants in today's call cover 9 different health systems and hospice providers. So
Wow.
I did want to share that your impact today has gone through, and I don't think we didn't count Providence in that. So 9 different health systems, and then 6 different associations or groups that do advocacy or collective education and things like that. So Justin today, who's listening to this conversation and the tentacles of engagement. So you're getting some happiness and thank you from, now that I've filled the void, are there any last questions from our participants?
Yeah,
All right,
love,
yeah.
yeah, love the use of AI, and I can't wait to talk about it with my IT, yeah, and folks about Epic Booth. I know I'm getting off this and sending an email to our CIO for the informatics stuff. This is incredible. Um, well, I will go ahead and wrap up because I just feel like, wow, what a blessing to spend this time with you all and have this conversation. Thank you to Dr. Gonzalez. Thank you, Dr. Fisher, for all you're doing to lead the work. And I really think in a national level. And I think biggest takeaways for me are some of the commonalities. You both have a dashboard. You both say incentive and buy-in is really a big key. Dr. Gonzalez from senior leadership, Dr. Fisher, I heard you say from clinical leadership for service lines that you're highlighting. Education, 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 and then really innovative utilization of Epic tools and AI. So that's the doing part. I think that my favorite part of what I heard is that you both said we need to listen better, we need to be curious, and we need to teach people to be okay with a whole, I like to say it's your rainbow of emotions, like all the emotions. You need to be ready for them in these conversations. And truly, how do we be with people better in healthcare? That's really what I'm taking away because I think this is about end of life conversations, but I also think this is about having conversations with patients in general, right? How do we develop trust with our patients? It's by listening and being curious and being with them first, and then we can help them with the doing part. So I can't thank you enough. And we're getting so many thank yous in the chat. It's an honor to have gotten to just spend an hour and a half with you. So thank you so much.
Thank you, everyone. And thank you on behalf of all of us at the North Carolina Serious Illness Coalition. Special thank you to all of our sponsors and an extra hug to Carinova for being our session sponsor. And really, Dr. Gonzalez, we let you, you're a friend from another coast, but you are a honorary North Carolinian. But really, thank you so much. And Dr. Fisher and Dr. Bowen, you're part of us. You don't get to go anywhere in the sense that we're on this journey together. So with that, thank you.